So kind of what we're going to go through is the Musculoskeletal Infection Society criteria, which has been very helpful at diagnosing periprosthetic joint infection. We also now have the new international consensus guidelines for periprosthetic joint infection. It's been helpful. The Academy Clinical Practice guidelines as well, and then I'll just go through a quick overview of a special circumstance that we're now seeing with diagnosing an infection with metal-on-metal and corrosion.
The treatment options for dislocated hips has varied over the years, from non-operative bracing, which we still do, and then a whole bunch of other options, including obviously revising malposition components, exchanging things, trochanteric advancement we don't do much. But I thought, and a lot of my colleagues thought, that dual mobility cups were going to be the answer to a lot of these problems and really eliminate the need for constrained liners. And unfortunately, that didn't turn out to be the case, as I'll show you.
Why do you use what you use? Well, the same reason that I use why I use. Because I like it, right? It's fun. And I get good outcomes. What else matters? So, there's this talk that, patients recover better. Therapists talk and nurses talk. And, what is this? Is it real? And compared to what? So, that's what we sought to understand with what we tried to create was a good study with comparable surgery, prospective level 2, 3 surgeons, mostly 2 with a couple of from third surgeon, comparing a direct anterior approach to a well-performed and well-closed posterior approach.
So I'm going to talk about navigation for hip replacement. Is it necessary? Does it work? Why don't people use it? Because for the most part, people don't use it. How can we make it more applicable so that more people will use it? So if we talk for a second about, is it necessary? The first question you have to say is, are there problems with hip replacements today that navigation could help solve? So what are the problems that we still have with hip replacements today? We still have issues with dislocation. We still have issues with wear, although crossing polyethylene has made that much less significant. We still have issues with impingement, and we definitely still have issues with leg length inequality.
The questions I have for you, though, because I see people with anterior approach, and I have nothing against it, but I will almost feel like the people that do it, there's some underreporting, and maybe you could shed some light. I've seen some people that have anterior approach, and they actually have pain anteriorly where the incision is, and they also have trouble externally rotating. And I've seen a few people that have had an anterior approach and they don't get full external rotation. Is that something that you see, or did I just get lucky and just see those, handful of people that have had that problem? Or are there people in the audience that have also seen that?
I would ask you to think back to the variability in execution of the posterior approach that you saw when you were a resident. That's good. Now take that variability and triple it, and that's what happens out there.